here is start our conversation. As I said, talking today with CCO leaders. We're going to talk about the key challenges and opportunities to address concerns in Oregon. And coordinated care organizations are central players in that agenda and in those efforts. So we're going to kick this off now. We're joined today by 3 leaders from the CCOs. We have Mindy Statlander from the Health Share of Oregon. We have Seamus McCarthy from Yamhill Community Care, and Aaron Fairtaylor from Pacific Source. So I'm going to sort of pose some questions to you all. And the first question is really, first start off by telling us just a little bit about your CCO and what you're working on. And then if you could share an initiative that you're particularly proud of and an effort that's contributing to the kinds of issues we're going to be talking about today. So Minnie, I'm going to go ahead and start off with you, if that's okay.
Thank you. Thanks for having us this morning, and good morning to all of you. I'll say it has not gotten old yet to see like old friends and new ones in 3 dimensions. So thank you for taking the time to be here. So Mindy Statlander from Health Share of Oregon. We are CCO in the Tri-County area in which you are at the moment. So we serve members in Clackamas, Multnomah, and Washington counties, about 460,000 members. One of the cool things about the challenges that we're dealing with right now is just continues to be the set of stakeholders around the CCO table. You know, in the beginning, we were formed to be local to each community, to bring a set of leaders and advisors and community members around a shared table to figure out how to address Medicaid's most challenging problems. And I still really believe in that model and believe that it's key to the set of complexities that are in front of us. I think we certainly need to evolve to bring in new sets of partners as we look forward to the waiver and implementing the new health-related social needs benefits, but that foundation, I think, is really critical. What we are spending the most of our time talking about these days is access and capacity in the behavioral health system. This year, in partnership with Care Oregon, HealthShare made investments in key parts of the behavioral health infrastructure, in low barrier access to substance use treatment in each of our counties, and in withdrawal management, and in some data infrastructure to better understand the size and nature of the challenge that we're seeing in front of us. In partnership with CORE, I know those folks are over here, the Providence Center for Outcomes Research and Education, we undertook an analysis to look at the high complexity behavioral, several high complexity behavioral health cohorts. So folks with an opioid use disorder, a stimulant use disorder, or complex mental health issues, and to understand what's been happening since the pandemic. It was really interesting. What we learned first is that the size of the population hasn't grown that dramatically. What we're seeing is an increase in the level of acuity of that population. So just knowing that has shifted the way that we're thinking about the investments that need to be made, the set of infrastructure, who we bring around the table, all that sort of thing. We're finding that that cohort is driving about 40% of our medical hospitalizations, and that resonates with what we hear from our hospital partners, that discharge planning is more complex, that the level of acuity of people that are in those wards is higher, and we need different set of services. And then if you layer on knowing that someone has unstable housing, those rates go even higher. So I just share a little bit about that because that's what's taking up much of our conversation. I think it's the right place to focus our energy, and we're figuring out how to wrap our arms around what is needed, what existing disparities exist within those populations so that we can better design programs to meet specific community needs and to organize across not just healthcare, but our housing partners, our mobile crisis, and county partners to do a better job in responding.
Thank you. Seamus, how about you? What do you got?
Yeah, good morning, everyone. It's great to be here with you. It's hard to believe that we're coming along 11 years in the CCO world and the successes that have come with it. You know, CCOs and the coordinated care model empowered local communities to have conversations regarding how healthcare needed to be provided in their local community. And in our community in Yamhill, we started having conversations. Providers of all types, medical providers, dental providers, behavioral health providers, providers across the social needs network, housing authority, county officials. And we decided that a community-based governed model was exactly what we needed in our community, and really worked together to build that organization from the ground up as a 501c3. And what this model has done by empowering the community to create this model, not only were we able to increase access to Medicaid folks by nearly 300% in our community, we also were able to increase access to behavioral health services and SUD services by more than 200%. We were able to grow our peer support network by 400% in the last 11 years. Not only that, but we've been able to meet metrics. So our community is healthier, and our members are better off than they were before. And this is quite amazing. But it's not just empowering the CCOs to do work in the medical community. It's also empowered communities to convene around other issues too. For instance, we're also the early learning hub in Yamhill County. And so we invest heavily now in the first 1,000 days of life, because we know that getting ahead of the curve, getting kids and families healthy first before they get sick, is best for them, and it's best for the system as well, and the community overall, healthier community. We've been working with the county and the housing authority to fund housing projects and transitional housing projects, and those have been really successful programs in our community. We've engaged educators and invested in school initiatives that help children be able to read at the third grade reading level, have a higher chance of graduating high school and going on to college and getting a good job. And now we're seeing that in some of these initiatives that not only are these kids more successful, but as adults they have less incidences of chronic diseases like high blood pressure and diabetes. And so when we look at this, the CCO model, it's not just a healthcare success in keeping costs low and increasing access. It's also about being a convener to convene the community in many different forums. And I think that this model has been a very successful model, and it's built the local networks and the local relationships and partnerships that we need to now approach the opportunities and the challenges that we have ahead of us. For instance, in health-related social needs network. I think we're poised now to go to the next level, and I think it'd be an interesting conversation to see what the new triple aim is going to be over the next 11 years.
Thank you, Seamus, and we'll dive into those issues in a second as well in terms of those challenges. Erin, what do you want to share?
Sure. Good morning, everyone. I'm Erin Fair-Taylor. Pacific Source holds 4 CCO contracts across the state. We operate and manage CCO services in Central Oregon, Lane County, Marion Polk counties, the Columbia Gorge, as well as in partnership with HealthShare with our partner Legacy Health as one of the integrated delivery systems managing services for HealthShare members. We manage services for about 350,000 Oregonians in all of these regions. And even though we have a very large geographic footprint, like my colleagues, CCOs here, we manage those through local health councils that really oversee and convene local stakeholders in each of those communities. So we have separate governing bodies, we have separate committees that oversee our clinical advice and set our strategy around our clinical approaches, community advisory councils, and a multitude of other committees that are engaged in the actual local provision of care and services. And I think the magic of the CCO, as my colleagues here said, is about that convening. I've often said that if CCOs go away tomorrow, and I hope they don't, but if they were to go away tomorrow, some of the connections and the light bulbs that have gone off over the past 11 years, where you've got disparate parts of the system that touch the same member, are connected on some sort of continuum, whether it's fully coordinated or not. We've got people sitting across the table saying, I had no idea why this part of the system operated that way. I understand it now. And those aha moments are what give us the opportunity to transform, make better connections, change where it's not serving the needs of our members, and adapt and ultimately keep costs low and result in better outcomes. We're focused, not surprisingly, on many of the same things. All of our communities, our country, most of the world, I think maybe right now is dealing with workforce challenges, difficulty with access, particularly in behavioral health and particularly with services offered to culturally specific parts of our population. So we've got a number of programs to help with recruitment and retention for the behavioral health workforce, as well as with particular emphasis on those that serve culturally specific groups or subpopulations that are at higher risk. We also are looking at the throughput. We know that the hospital is often not the optimal place to keep people certainly longer than they need to be there, but we don't have great discharge options, and so we're working across communities to identify options to help with that throughput, get people out of the hospital setting closer to home, and with supports that they need to manage their care post-discharge. We're also working with a number of housing providers. The state of Oregon has a regulatory scheme within the CCO framework that allows us to invest a portion of our restricted reserves in housing. So instead of those dollars sitting in a bank account to reserve against our risk, which we need to do to be prudent, we can invest those in real estate and property to help with the housing crisis that we're experiencing. And so we've got a couple of initiatives in play right now to help us to utilize those dollars to help with the housing stock. And then finally, we are in a paradigm shift. This post-pandemic environment that we're in has caused, it's brought most of the delivery system to its knees. We've got some really difficult questions ahead of us when it comes to sustainability of our healthcare model, of our delivery system, and the resolution to some of those really intransigent challenges cannot sit with CCOs. And I know we'll talk about some opportunities, but one of the things that I'm really optimistic and hopeful about, in spite of some of that doom and gloom, is that we have these existing tables that have our hospitals, our specialists, social service providers, counties, community-based organizations, and our members. So we have the table there to have the really challenging conversations about how do we move forward, how do we ensure stability of our system, and ultimately how do we make sure we get people connected to the services that they need to live their best, most healthy lives.
So let me pull that thread a little bit. You've each talked about the vision behind coordinated care shaped by community governance, by community engagement. It's challenging, right? And not just because of the community challenges you all have talked about, but also because partnerships are difficult, rules are out there. I'm going to start with you, Seamus. What do you see as being a bump in the road, an obstacle, something you think needs to change in order to continue the progress of the kinds of opportunities that we have to reach that vision?
Yeah, thanks for that question. I think that I'd like to see us work closer with OHA and the governor's office for a long-term vision and strategy for what we need to do in healthcare transformation going forward. And that starts with collaboration. The CCO model was a collaborative effort between OHA and the state and the legislature and local communities. And that sort of partnership is what's needed to go forward to approach challenges that are in front of us today. When we talk about workforce, for instance, we all know that that's a big challenge. I want to give you an example in our community of what we're doing around workforce. Now, it's not in the medical workforce. It happens to be in the child care workforce. Now, you know that the first 1,000 days are extremely important when we talk about healthy families and healthy communities. And so one of the things that we're doing is leveraging some ARPA funds with the county, the business association in our county, the CCO, the housing authority, and other community members, child care providers, of course, to increase the number of child care providers in the county. So we'll create a center where they're going to be educated. We're going to train them. We're going to pay for their licensing and get the supply of healthcare professionals needed, child care professionals needed in the community in order to provide the important care that's needed. for our community. Now, we can do that sort of effort in behavioral health too, but it takes partnership and collaboration, a public-private partnership to bring many folks across the community together, including developers, giving them incentives, to build housing, for instance, right? But with the behavioral health workforce, if we come together and we establish a partnership around the workforce development, that work can be done. But it takes a vision around that. It takes collaboration and partnership. The housing I just mentioned is a big issue for us. We've got health-related social needs coming on, and we have a wonderful, amazing opportunity here. I mean, I see this as like almost an opportunity on the scale of CCOs back 11, 12 years ago. We really have an opportunity to change people's lives here and increase their health, and also the health of the community. And so I think, though, however, we can't provide our housing benefit when that comes online next year if there's no inventory. And so working together in public-private partnerships is going to be key in order to make sure that the health-related social network or needs is actually going to be successful. And the nice thing, though, is that the community-based model is the foundation for us to do that. The relationships, the providers, the networks are already there. We just need to establish them and develop them. And so I think we have some amazing opportunities going forward, challenging for sure, but partnership and collaboration is going to be at the center and the key to our success.
Erin, do you want to share your thinking about the challenges?
Sure. So as I mentioned earlier, I think we're in this paradigm shift, but the thing that I think we can hold on to as Oregonians is that, as I tell my kids all the time, we can do hard things. As a state, I think we've proven that we've got the political will to take on really challenging issues. We now can proudly say that we offer insurance coverage, Medicaid-like coverage to everyone in the state, up to 138% of the federal poverty level. That's extraordinary. We are going to be among the states with the lowest uninsurance rate, and we've covered kids for many, many years now, which is also extraordinary. Now with the 1115 waiver, we'll have kids up to age 6 with continuous coverage, and almost everyone else will have 2 years of continuous enrollment. All of this gives us a really extraordinary platform to think about how we get ahead of the cost curve, how we really emphasize prevention, how we think about managing what I said is this paradigm shift of getting out of an overly expensive, frankly unsustainable delivery system model, and enable us to get to whatever the future state is in a way that can be, world-class care, as Dave Ford used to say many years ago. When the ACA passed, what we saw in that piece of historic legislation was that it would expand the availability of coverage to many folks, but it didn't make the kind of meaningful transformation in care. And I think we're on that same precipice here in the state of Oregon, where we've got the policy framework in place to ensure that we've got historic numbers of people covered, but now we need to do something with that opportunity. And it's going to be about meeting people where they are. That means making care that's linguistically appropriate and responsive to people's needs, that we're doing outreach and engagement activities with a variety of populations that have been marginalized and may not know how to access the system. System may not be built for them. It's also going to be about getting upstream, and we've got a real opportunity with the health-related social needs and some of the upstream metrics that CCOs are working on around social determinants of health, et cetera. And so I think it is about, as Seamus said, pulling people together to start really digging into what does that mean? How do we ensure that we're developing the system that we need in 10 years, in 15 years, in 20 years, and not just putting out the immediate fires of right now. And some of the regulatory framework that CCOs are working under right now require that we make these one-year investments. So we're making these very short-term, shovel-ready investments, or putting out immediate fires, or spending CBI dollars, or checking boxes just to meet our CCO contract needs that don't allow us to take the longer view. And so I would encourage us to get creative, maybe work with policymakers and others to figure out how do we how do we use those dollars so that we're making longer term, generational investments instead of these smaller, one-time only spend by December 31st of this year types of investments.
How about you, Mindy? You in alignment here, or you?
Oh, totally. I'm like absorbing the wisdom of my colleagues and totally agree. I think we have so many great things that we have done together, and keeping that optimism in that we have a strong foundation to build from is really critical. I think, CCOs started with a call for integration, and it might seem simplistic at this point, but that was really about primary care and hospitals and behavioral health and dental, and now we have those lessons learned from building those foundations, setting those tables, to what is called for now, which is a whole new set of partnerships, community-based organizations, counties, other sets of social service providers. And so we've got the foundation to build from. I think that what's hard is because of the level of opportunity, we're implementing the basic health program. We're implementing the health-related social needs benefits. We just expanded eligibility, which I feel like it's a secret for me, but that's the part of the waiver I'm the most excited about, creating that set of access. We're looking forward to thinking about how do we extend Medicaid benefits to folks in a carceral setting before they're discharged to smooth transitions of care. Those are hugely important things, but a lot of big lifts. And so building on those lessons of partnership, how to be able to say, hey, we got to slow down for just a second because we didn't get this right, so that as we go to implement, we're sure that we're serving the communities in the ways that make sense to them. Building in that set of foundational principles about how to do that community governance, I think, is really important. And grace for each other. This is a lot of stuff that we're doing all at the same time. I'm so optimistic by that cross-sector set of partnerships. I forget which one of you said it, but CCOs cannot do this alone. And we're poised to be able to do better by way of the communities that we serve if we're able to rise to that challenge.
Very optimistic in terms of lots of opportunities, right? That's one way to see it, but it is a lot of challenges. We are going to have a chance for audience questions before we end, but let me run down the table here a little bit. I'm going to start with you, Erin. Anything we haven't talked about, anything that you feel like in those list of opportunities that we do have, where are the things that are really going to slow us down? The expectations are high, and not just here in this state, but federally, nationally, other states are looking at this. Does that present a risk? Where do you sort of see the risks right now?
Yeah, I mean, it's a little trite to say, but so much of this depends on moving at the speed of trust, and especially as we're working with new to us partners, especially in the CBO space and social services and members, we can't get in front of them, and we can't medicalize this work that we're doing. Also trite to say, but if you want to make something 10 times more expensive, give it to medical system. And we can't afford to make food 10 times more expensive. We can't afford to make housing 10 times more expensive. And so I worry a little bit about the administrative load of some of these health-related social needs and upstream types of services that are absolutely the right thing to do. But I worry that the CCO/medical environment may not be the best place to manage some of those. I think we're a stakeholder in it, and we'll certainly drive towards it and support it in the best way that we can. But I will be doing everything that I can to make sure that it doesn't become a claims encounter, even though we have to do some of that, type of medical care program, that it does stay truly community-based and part of the social fabric. We can't solve all of society's ills through our medical system.
Great point. Seamus, what do you think? What's the risks here?
Yeah, well, the first thing that comes to mind, I'm just going to talk again about health-related social needs, because that's a big thing on the horizon for us. And as I think about that, as I mentioned before, there's a lot of opportunities here. I think it's a really exciting opportunity. A lot of challenges to get that up and running. to get the systems, the networks, the claims payment processes, all that it is in order to bring on a new type of benefit. What I worry about is, what's the sustainability of the health-related services needs idea? When CCOs, came about, the idea is that we're going to keep costs low, saving money for the system, and then taking any margin that CCOs might have and reinvesting it into the community, right? Social determinants of health investing so that you keep people healthier and use the sick system less often. I'm concerned and a little bit worried about HRSN is how do we manage this and afford it long term? And I haven't heard a whole lot of conversations about that. And so as we take on more challenges in our system and we put more expectations onto CCOs and local communities and providers, I think we need to have these very important partnership discussions on what that looks like going forward and what the plan is in order to make it successful. We don't want the 5-year demonstration project. I mean, it's great that the feds are giving us almost $1 billion to do health-related social needs, but what happens after that? What's the 5 to 10-year plan in making this sustainable? I feel there was a decent plan for CCOs in the model there. I think we need more conversation about that.
I think for me, it's probably the workforce. I think particularly maybe circling back around to behavioral health, with the level of acuity in the population that we're seeing right now, the level of need at the moment that we're in, making sure that we have a workforce that is well supported, ready to respond, that we are making up for 30 years of underinvestment in the behavioral health system. That's real. That's not going to get solved overnight. And so that kind of sustained investment and attention to both the capacity that we have and the providers who are delivering that set of services, I think is really critical and is going to be a rate limiting step to what we're able to do in the future. I'm really heartened by, health share raised rates by 30% for most of the behavioral health network, and then OHA just did it a year ago statewide. I'm super proud of that. I think that's a great first step in making sure that we have that robust workforce to make that an attractive job option. But I think the partnerships across train your own workforce development programs in our communities, to our community colleges and our state universities to make sure that we have the workforce to be able to respond is important.
Great, thank you. So they've all used the word partner. That's you all. So this is an opportunity for you to ask questions or put something out there. So any questions from the audience? Oh, I see one back there. Vaguely, I think.
Hi, thank you. Julie Akins, All Care Health. I'm listening to this conversation about partnerships, and it seems to me many CCOs have had long relationships in our communities with our community-based organizations and in reaching out around HRSN. So I understand the concern, but yet I don't, because we've been doing the work, and I think we'll continue to do the work. So what am I missing here?
I'm not sure.
Well, because we're raising the flag that there might be a crisis around CCO's ability to continue to have these deep roots in our communities, but I don't feel that. As a senior housing director and community liaison, I think we know, many of the CCOs know every hair on every head in the CBO environment, as well as many of our members. And I think it's a great model. So yeah, help me understand.
I agree. I'm not sure I fully follow your question, but I think what I was trying to indicate was that by creating a system where we are encountering and claiming some of the community-based services, that we are at risk of over-systematizing something that really is about social services. And so I agree. I think it is a great model. It is not a criticism. It's just a worry that I have that by creating more of a benefit structure rather than some of the flex model that we've had for history, that we will create a more overburdensome administrative load for something that has worked well historically.
Thank you for the clarification.
Sure.
Could I take that, Kathleen? So I don't see the issue necessarily as being at the local level. So I appreciate the question. Yeah. And it is a great model. And I think that as I was mentioning earlier, that local communities were empowered to build these relationships and these networks. Now, do we need to continue to build those partnerships? Absolutely. Do we need to strengthen them? Of course. Do we need to bring more people to the table? Yes. Where I see partnership and collaboration is needed is more at the state level with OHA and other state organizations. A lot is being talked about in the CCO world about CCOs doing something about workforce development. Well, we can only do so much. And so where's the partnership and the collaboration in establishing initiatives and programs and opportunities to build that workforce across the state? It's the same with housing. A lot more is being put on CCOs to provide housing. And where does that housing come from? We in our community do take dollars and invest with the Housing Authority and the county and other organizations to build housing or to turn hotels into transitional housing. That's not going to be enough. And the housing issue just isn't about our members needing housing. There's a housing shortage for everyone. When we talk about workforce and trying to get people to come to our community and work in our community and they can't find a place to live, well, that just adds to the problem. And so that's when I say partnership and collaboration, these are big system issues that can't be handled or solved in a silo or one particular part of the system. There needs to be partnership there. And that's what I'm talking about when I say partnerships.
We have a question up here. Oh, here you go. Thanks, Shane. Here at the front table. All the way in the front.
Thank you. Michael Huntington, retired radiation oncologist from Corvallis. With the CCOs, there's a capitation system which incentivizes providers to avoid high-risk patients. That's the first question, how would you reduce this tendency, this incentive to avoid high-risk patients? And then how do you feel about the governance board that was established by Senate Bill 1089? Are you interested in it? And if you are you going to take part in it and help it come to a good conclusion?
Thank you for those questions. Anybody want to take the first one?
Well, I'll start with the first one. So I think that, at least in the work that we're doing at the moment, we are looking at where high-risk folks are engaged in care right now, and they are engaged in our delivery system. Providers, primary care, behavioral health providers, community service providers, hospitals see them on a routine basis. What I think we have the opportunity to do is to build a better system that actually meets their needs and brings them on a path to wellness. And so for me, that is having conversations about where do we have centers of excellence that bring a set of really robust wraparound sets of services. What additional programs in the hospital setting make sense? OHSU has been experimenting with an impact model. So when someone is in for a medical service but needs SUD or behavioral mental health services, they can wrap that set of services around. So I think it's more about how do we design programs that meet the needs of a whole person and make sure they're getting to the most appropriate source of care.
I would also just add that what we're trying to build is a system, this is a longer term strategy, but this, to get to your point, a system where we're prospectively paying for the kinds of services that we want to be there all the time. We want primary care to be there when we need it to be there. We want behavioral health to be there when we need it to be there. Kind of like you want your faucet to turn on when you need it to turn on. But we pay for episodic care, so the kind of, high-risk patients, episodic care, you only need to get your gallbladder out once. For example, we pay for episodic care really differently. And so by doing that, we're keeping the infrastructure in place for the kind of standard, what we need all the time when we need it care, and that we're propping up and ensuring the infrastructure is there for when the episodic events, pop up. And I think if we can get to that in a more stable way, then we'll have a more high-functioning, sustainable system, and that doesn't discriminate against those that are higher risk.
And I guess what I would add to that is I would want to look at that, but we're really talking about value-based compensation at a capitation. And so what I'd really want to look at that arrangement, because the idea of capitation and value-based pay is that we're paying for outcomes and quality. And so when we do that, so for instance, we capitate our primary care, a couple of offices now, we've done this for a few years, and they want to take more members. And our members are higher risk than the average population. And the reason is that is the capitation, but also they get paid for quality and outcomes on the back end. And so there has to be a balance in that capitation agreement. So I think that's the way to solve what that dilemma is. And as far as 1089, I'm sorry, I don't even know what that is. Apologies.
I'll be happy to say something about it when there's time.
Well, we will certainly come back to that. I don't know if any of you have. I've read something about it, but that was purely from an article. So, well, we will have to come back to that one. I don't think it's on the agenda yet. Let me do this. We have just a few minutes. Let me sort of close this out, and if there's any closing comments, we'll do that. We've heard a lot about partnerships. We've heard a lot about creating some structure, but not too much structure. I think that's kind of the balance word that you just used, Seamus, I think is certainly part of what we're looking for. And as we started the conversation, CCOs are a big player in what goes forward. We are going to be doing, just to plug my own session, a conversation about the 1115 waiver in a little bit, as well as other issues in the breakout sessions like workforce and behavioral health, as well as rural issues, et cetera. So any closing comments, anything you didn't talk about that you want to share? You think you covered the waterfront? You're right.
I would just say,
yeah.
I'm sorry, I'm just
No, please.
I would just say, hey, we talked about a lot of challenges. Nothing's, it's not perfect. And building the CCO model hasn't been perfect. And it's been a lot of work and a lot of challenges. We've learned a lot from things that maybe didn't work, right? We have some amazing opportunities here in the future. And we are really innovative here in Oregon. And we do find ways to make things work if we work together. And we're all in this together, and I am very hopeful in the future here for healthcare transformation going forward in Oregon.
And that's the kind of partnership that we look for in these State of Reform conferences. So perfect wording. Thank you, Seamus. Please join me in thanking the panel for their comments.